Good evening, everyone. We welcome you to the next episode of the web series Inspire and Ignite, organized by ISAR Haryana with academic partner Jagsonpal Pharmaceuticals Ltd, NAARI division, makers of Endonorm EV2 and LycoRed-M. Today we have powerful talks and panel discussion on the topic of endometriosis unplugged with esteemed expert faculty among us. We thank and welcome the faculty and a very warm welcome to all the attendees present with us today. So now we hand over the program to Dr. Jyoti Malik, Chairperson ISAR Haryana. She's the Director of Roots IVF and Fertility Center, JJ Institute of Medical Sciences at Bahadurgarh, Haryana. Ma'am, please initiate the session.
Thank you. Thank you, Dr. Deepika. Thank you, Jackson Paul, for the platform. And ISAR Haryana, with the motto of Prayas Evam Vistar, is organizing this third series of Inspire and Ignite with the focus on endometriosis and with the aim of, with the motto of Endometriosis Unplugged. And with the blessings of our President ISAR, Dr. Ameet Patki, Honorary Secretary General ISAR, Dr. Asha Baxi, I welcome you all on this platform with my team, ISAR Haryana, Secretary Dr. Meenu Handa, Clinical Secretary Dr. Majumdar, and Treasurer Dr. Lakshmi Goyal. For this series, we have conveners, specifically our chairpersons of this endometriosis committee of our ISAR Haryana, Dr. Jatinder Chadha, who is the chairperson, Dr. Lakshmi Goyal, the vice chairperson, and Dr. Gurnesh Singh, also the vice chairperson of the endometriosis committee of ISAR. And for we are lucky to have our chief guest, Dr. Sujata ma'am, who is vice president of ISAR, and she is a person who is one of the pillars of ISAR, an academic person, a thorough academic person, and I think a fitness freak and an academics freak, I would also add. And ma'am has been practicing endoscopy and assisted reproduction for the last 27 years. Her areas of interest are polycystic ovarian syndrome, proteomics of male infertility, and the scope of stem cells in gynecology. And she has been credited with the first IVF baby of Eastern Orissa, first TISA, frozen embryo, and laser hatched babies of Orissa. And Orissa witnessed a wonderful, wonderful national ISAR in January this year. And ma'am was the show woman behind the whole show. She has multiple awards: Parichya Award for the Women Achiever, Devi Award for Dynamism and Innovation from the Chief Minister of Orissa, and the Brand Icons Excellence Award of 2018 for Best IVF Center in the Eastern India. She has 15 original publications related to PCOS, male infertility in PubMed, and has written many chapters for books and newsletters. Presently, she was the General Secretary of ISAR India and EC member of IAGE and various societies. Over to Dr. Sujata ma'am for your words of wisdom and your blessings. Thank you, ma'am, for joining.
Thank you so much, Jyoti, for giving me this honor to be the chief guest in this fabulous program. It sounds so good, Inspire and Ignite. It means not only ignite you feel is for younger, generation or people, but I think Inspire and Ignite also is so much needed for all our ISAR members to, get so much active and take part in ISAR activities and to take ISAR to another level when we can be recognized globally as a world leader. That should be our aim, and I'm so happy to see you, Jyoti, as taking over as the chairperson of Haryana ISAR with your secretary, Meenu Handa. I know you so well for so many years. Meenu also I know, but I may not be knowing her as closely as I know you. And I know that you will be doing a lot academically for ISAR Haryana as well as for ISAR, the Central ISAR. So endometriosis is another great topic that you've chosen for this webinar, and you've selected an excellent set of speakers. Thank you so much once again, Jyoti, for having me. Thank you.
Thank you, ma'am. Thank you. Dr. Meenu, over to you.
Thank you, Dr. Sujata, ma'am. This really means a lot to our team. And now I would like to invite our guest of honor, Dr. Asha Rao, ma'am. Ma'am is always known for her graceful and a very vibrant smile. All of us know her. She is the director of Rao Hospital and CARE Coimbatore, director for so many postdoctoral fellowship programs in reproductive medicine. And Madam has been the chairperson of Endometriosis Committee FOGSI 2020 to 2023, a past president Coimbatore OBS-GYN Society 2017 to 19. She's also been the organizing chairperson for many very important and successful conferences held in Coimbatore. And Madam is the editor for FOGSI Focus on Endometriosis, convener for FOGSI GCPR on endometriosis, and co-editor for the book on endometriosis clinical management. Madam is also known as credited to deliver the first ICSI baby of Coimbatore in 1998 and first vitrification baby of Coimbatore in 2008. So, ma'am, we are eagerly looking forward for some words of wisdom from your end too.
Thank you, Meenu, for those kind words. It's a great pleasure for me to be here today at this Endometriosis Unplugged. It's a fantastic name invented by Jyoti and Meenu together. Very glad to see that Jyoti is taking over as the president of Haryana chapter and Meenu, the vibrant girl, as a secretary. I've seen the passion of Jyoti over the last 4 years for endometriosis. Ever since I started my tenure in endometriosis, I think I have been interacting with Jyoti over very many meetings. And today we have fantastic speakers, Dr. Abha Majumdar, who will tell us a lot about the ovarian stimulation for endometriosis. And we have none other than Sandesh Kade. We have seen Sandesh Kade operate with us. We have heard him talk. He's such a fantastic speaker and surgeon for endometriosis, and we are very eagerly looking forward to his talk on endometriosis. And then at the end of it, we have again a very nice panel discussion by none other than Jyoti Malik moderating the panel. I'm sure it is going to be a wonderful saga of knowledge. And thank you all, and let us all enjoy this session on endometriosis together. Thank you, Jyoti, for having me here today.
Thank you so much, ma'am. It is an honor indeed for us to have you. You are, whenever I think of endometriosis, I can just see you and you only. So thank you so much.
Thank you so much.
Next, we have our third guest of honor. Dr. Anu is a very academic person who has contributed a lot to FOGSI and ISAR. And she is chairperson of the Endometriosis Committee of FOGSI, and she is director of the London Fertility Clinic. And we welcome you, Dr. Anu. So moving on, I think we come on to our scientific part now. And can we have the CV of our first set of chairpersons? Yeah, Dr. Jatinder is, as I've already told you, is now the chairperson of the Endometriosis Committee of our ISAR Haryana. She is also founder president of the Yamunanagar OBS-GYN Society, consultant at Yamunanagar Srijan IVF, and executive member of various committees. Next, we have Dr. Sangeeta Jain. She is in charge of the Vridhi Fertility Center, Ambala, and a life member of many societies, founder, president of the Society of OBS and Gynae of Ambala, that is SOGA. Next, we have Dr. Shweta Jain. She is founder of the Jain Gynae Club, which holds all the academic meets every month, and representative of the Jain district in Mission Pink Health, executive member of many societies, and receiver of the Haryana Chikitsak Gaurav Award 2022. Next, we have Dr. Sonum. So Dr. Sonum is also a very active member of our society. She is trained at Sir Gangaram itself, and today we have also speaker Dr. Abha ma'am, who heads Gangaram IVF Center for so many years, and so we are all looking forward to listen to have you, ma'am, and I now give over to our chairpersons to introduce Dr. Abha ma'am.
Yeah, good evening, everyone. Myself, Dr. Shweta Jain. First of all, I would like to congratulate Dr. Jyoti Malik and Dr. Meenu Handa and their team for bringing this wonderful concept of having webinars on different important topics separately and involving people who are interested in these particular topics. I would now take the privilege to invite Professor Dr. Abha Majumdar. She is a stalwart. She is the director and head of Center of IVF and Human Reproduction at Sir Gangaram Hospital, Delhi. She is one of the pioneers of IVF in India. She has been in the team of first IVF baby in 1991 and first frozen oocyte baby born in Jan 2009 of Northern India. She is a proud receiver of many prestigious awards, starting right from her medical college days, including President's Medal Award, Chancellor's Medal Award for Best Girl Medical Graduate. She is facilitated by DMA for BC Roy's Birthday Award 99, Nation's Vikas Ratna Award in 22, Chikitsa Ratna Award in 2007, Medical Excellence Award Lifetime Achievement in 2014, Abdul Kalam Gold Medal in 2015, Rashtriya Gaurav Gold Medal in 2017, and the list is very long. She has also received many awards like IVF Champion, Icon of IVF, Best Team of IVF, and Pioneer in IVF. She has also received the Distinguished Teacher of Excellence Award in 2019. So without taking much of the time, I proudly invite Dr. Abha ma'am for her words of wisdom. Welcome, ma'am.
Thank you, Shweta. And I will straight away start the topic. Thank you, Jyoti, for having me over to talk in this interesting topic. And this is controlled ovarian stimulation for IVF in women who have endometriosis. Why does one have to think differently for ovarian stimulation in women undergoing IVF with endometriosis? There are certain conditions which make us think differently. One is most of these women have lower ovarian reserve because one, the disease is in the ovary, and if she's had a surgery, then the surgery also involves reducing the ovarian reserve further by pulling out some of the cortex. Then the egg quality and hence the embryo quality may be affected negatively, again because it is a diseased ovary from where the oocytes are coming. And last of all, the implantation, the soil, impaired endometrial receptivity. It is very well known that with large endometriomas, there's lower expression of FOGSI-10 and alpha-5 beta-3 integrins, or if there is associated adenomyosis, further on there is reduction in receptivity because of the cutting off of the blood flow to the endometrium. So all these things together change the outcome of IVF in women with endometriosis. What does one need to consider to develop an ideal protocol for IVF in endometriosis? We need to see what is the age of the woman, what is the ovarian reserve when she's come demanding IVF, what is her duration of infertility, and what is the stage of endometriosis. So having said that, what would be the aim of our ideal protocol? The aim would be good number of high quality oocytes, best endometrium for implantation. These are two prerequisites for us to have the best pregnancy outcome. Now, because endometriosis is a disease which we feel is affecting the quality of eggs, or it is affecting the number of eggs. So when do we need pre-treatment before controlled ovarian stimulation for IVF in these patients with endometriomas? Now, suppose a patient presents with endometrioma, there is pre-treatment. It could be surgical or it could be medical. So when do we need to do surgery or medical treatment before IVF? Is surgical pre-treatment when the diagnosis of endometrioma is in doubt, large hydrosalpinx with bilaterality. I emphasize here bilaterality because a unilateral hydrosalpinx really does not affect the outcome of IVF so much as bilaterality does. Follicles or ovarian cortex distal to cyst from the vaginal wall and the probe. Now, when you start aspirating and you find that all the follicles have developed away from the vaginal wall and the cyst is right in front. So for every follicle, you might have to go across the endometrioma. That is one condition which we want to avoid because
of repeated punctures, we can lead to ovarian abscesses. And intractable endometriosis associated with pain, no relief with medical treatment. So if there is intractable pain with endometriosis and no relief with medical treatment, then also surgery becomes a prerequisite. And if endometrioma is large, when I say large, it is like more than 100 cc's in volume, and the risk of infection is high during ovarian oocyte retrieval. So it's important to remember that these are the conditions where you would want to do a surgery before you start IVF or you do controlled ovarian stimulation for oocyte retrieval. When do you give medical pre-treatment or no pre-treatment? If the woman has had previous surgery or surgeries for endometriosis, compromised ovarian reserve, advanced age, large endometrioma with risk of infection high during OCR, yes, you might take the risk of infection. Sometimes when you feel that the ovarian reserve is too low, advanced age is too much, and then you think that, okay, let me just go in with IVF. Having said that, what are the two protocols which we use in endometriosis or in any case of IVF? One is the long GnRH agonist protocol and the antagonist protocol. So let us only talk about the standard protocols which are used. Either you're going to use something like Lupride or Buserelin from day 21 of a cycle to suppress the hormones and then start stimulation to get a good cohort, or you start straight from day 2 or 3 with gonadotropins and give antagonist on day 5 or 6 of stimulation. So these are the two standard protocols. Which is the ideal one? This is the question I'm often asked. Long GnRH agonist versus short GnRH antagonist in endometriosis have similar IVF outcomes. Actual impact of GnRH analog is on ovarian hormonal control and not on oocyte and embryo quality. When we give it for a short term, say in GnRH agonist, we've given it for 20 days. Antagonist, we've given it for 4-5 days. It does not affect the oocyte quality. It has to be given for very long times to really change the oocyte quality or change the impact of integrins on the endometrium or FOGSI-10. It has to be prolonged use of the GnRH agonist protocol. So this is a favorite diagram of mine where how I say what happens is there's retrograde menstruation, which produces intracellular adhesive molecule and fibronectin, and then the endometrial fragment gets adherent to the epithelial lining, which is there in the peritoneal cavity, which starts producing under the effect of VEGF and interleukin-1. These implants get neovascularization. And once they get neovascularized, the estradiol also reaches them. And as estradiol reaches them, they start proliferating. And the whole process of negative balance towards macrophage recruitment goes on happening. They are not cleared out. The NK cells go down, the B and T cells increase, and there is a whole negative cycle which starts impacting the oocyte and even the sperm quality. So long ago, a novel mechanism of action of prolonged use of GnRH agonist in endometriosis was proposed. It was followed for many, many years. And what did we feel? That there is suppression of ovulation, and hence this reduces exposure of endometriotic implants to a growth factor midkine, which is present in follicular fluid involved in proliferation of endometriotic cells. So if we do not let ovulation happen, we do not let follicles develop, then this midkine also, which is a growth factor for endometriotic cells, also suppresses. Direct inhibition of proliferation of endometriotic cells by regulation of apoptotic and angiogenic mechanisms. Both of these are down-regulated. Then inhibition of menstruation reduces exposure to thrombin. Now, every time menstruation used to happen, a new implants would form. That also is reduced, and exposure to thrombin and its protease activator receptor factor, which leads to cell inflammation. So once there is no menstrual blood, there is no cell inflammation in the pelvis. And once this inflammation subsides, then the protease activated receptor also sort of goes down. Then inhibition of uterine contractions blocks mechanical stress. So there is very little uterine contractions when the uterus is placid with GnRH agonist for 3 months, 4 months, or 6 months. And that also blocks the mechanical stress. So Cochrane Database Systematic Review 2006, Salem et al. This study is very famous because till many, many years, we kept on following this systemic review, and we thought, oh, ultra-long protocol was ideal for endometriosis because what it said, what it only could include 3 RCTs with 165 women who could be included in this. And he said that live birth rate in a woman is almost 9 times more if this is used, and the clinical pregnancy rate is 4 times. So almost till, I would say, 10, 12 years, we kept on thinking that this is really true, but it most of the times would not happen. It was not that we gave GnRH agonist for 3 months, 4 months, 6 months, and then we got better results. So again, Cochrane Database Systematic Reviews of 2019 came out with a different conclusion. And what did they say? Endometriosis is known to have an impact on fertility, and it is common for women affected by endometriosis to require fertility treatment like IVF, ICSI to improve the chance of pregnancy. And it has been postulated that long-term GnRH agonist therapy prior to IVF, ICSI can improve pregnancy outcomes. And this was the Cochrane review by Salem 2006. Now, this systematic review supersedes the previous Cochrane review, and it says, we are uncertain as to whether long-term GnRH agonist therapy impacts on the live birth rate, or indeed the complication rate compared to standard IVF ICSI. And in the light of paucity and very low quality of existing data, we cannot recommend GnRH agonist therapy to improve the outcome of IVF in women. So where do we go back to? We are again stuck with the long protocol or the short antagonist protocol. The ultra long protocol, which was promoted by Salem et al. In 2006, have taken a back seat because generally we find after such a long suppression, we do not get a good cohort of follicles. The ovary is almost sleeping. So there were more studies which came out at the same time. And then the meta-analysis was done in China, which was published later than the Cochrane review in 2020. And what did they do? The effectiveness of different down-regulating protocols on IVF embryo transfer in endometriosis. Only studies that met the following criteria were included in this meta-analysis, including cohort studies and RCTs. One is clinical study of the efficacy of IVF ICSI in the treatment of endometriosis in infertility patients. They took GnRH ultra-long protocol, GnRH, the normal long protocol, which you start from day 21, and the GnRH short protocol, where you use antagonist from day 6 of stimulation. Subjects of study were women diagnosed with endometriosis by laparoscopy, laparotomy, or transvaginal aspiration of the ovarian endometrial cyst combined with pathology. So they made sure that these were all cases of true endometriosis, either seen by eyes by laparoscope or laparotomy, or one did aspirate endometriomas and did a histopathology on them. What did they find in the RCT and non-RCT studies? Well, GnRH agonist ultra-long protocol could improve the clinical pregnancy rate of infertile patients in RCT studies, but the RR value, the relative risk, was 2. That means it increased marginally, and that also patients with stage 3 and 4. Whereas subgroup analysis of the non-RCT study showed that there was no difference in improving clinical outcomes in patients. So when we say non-RCT, it is, sort of a select group of patients where you feel that if you give down regulation, it would not help. So it was given in only selected group. Whereas RCT means you give it, one patient who deserves it, you give it, one who doesn't deserve it, you give it. So there they could see a little difference. So there were limitations of prolonged down regulation of this GnRH agonist. It was time consuming because all the down regulation is 3 to 6 months, nothing 1 or 2 months. Doesn't work. And there was diminished response, especially in poor responders, when we started stimulating these women. So they started finding other things. What are the medical methods to minimize negative effect of endometriosis on oocytes? Well, these are the 3 drugs which are being investigated, being tried, and we are trying to come up with a alternative recipe apart from what we had as long protocol, ultra long protocol. And we are trying to shorten the period of pre-treatment to maximum 8 weeks. So pre-treatment with OCPs for 6 to 8 weeks before starting IVF, COS for IVF, letrozole along with depot-GnRH agonist for 8 weeks. So we're trying to sort of bring a lot of effect of the GnRH agonist within a small period of 8 weeks by combining it with letrozole, which further reduces the estradiol levels, and Dynogest pre-treatment for 3 months. So these are the 3 drugs which are being explored and have been explored. Dynogest, well, the highlights are IVF has worse outcomes in patients with endometriosis. Prolonged use of hormone drugs before IVF may improve pregnancy outcomes. And Dynogest is a progestin with anti-inflammatory and anti-angiogenic activity. Implantation rates may be higher as a result of receiving DNG before IVF, and clinical pregnancy rates also. So these are just the thought, and this was published in RBMO. So what was the study? Pre-treatment with Dynogest in women with endometriosis undergoing IVF after a previous failed cycle. And this was published in 2020. Let us see what they say. This study was based on the retrospective analysis of a prospectively collected database, including 151 women who had failed a previous IVF cycle. So all you want to understand is that they took all failed previous IVF cycles, and then they put these patients on Dynogest 2 milligram daily for 3 months. What did they find? They found that the largest diameter of endometrioma significantly decreased after DNG pre-treatment with a significant p-value. The number of oocytes increased with a significant p-value, and so was the fertilized embryos and blastocysts. So the study does suggest that in patients with endometriosis, IVF outcomes can be improved by pre-treatment with DNG, and the suppression of ovary is not as severe as it is with GnRH agonist ultra-long protocol. So let us come to the next drug. Again, this was DNG, again, another one by Hiroshi Tomara. And this is from a Japanese group. Here, results were retrieved oocytes, fertilization, blastocyst formation rates were lower in the DNG group than in the control group. Cumulative pregnancy and live birth rates were also lower in the DNG group than in the control group. So it is very important for us not to start running and changing our protocols on one published study, because the whole world is researching on this, and we feel that just one study has a good result doesn't mean that the results are always good. It could be patient selection, it could be study protocol, it could be the way analysis was done. Because in the same time, another study says that administering DNG treatment just before IVF-ET did not provide any benefit to improve clinical outcomes for infertile women with endometriosis. So this is still hanging in a question mark in front of us, whether we should use Dynogest or we should not use as pre-IVF treatment. Let us go to the effect of, again, the same Dynogest and ultra-long protocol. Now here again, this is by in 2021, and this study says that they used Dynogest vis-a-vis GnRH agonist for 3 months. And what did they find? It indicated that Dynogest is a suitable and safe substitute for ultra-long GnRH agonist pre-treatment in endometriosis patients. Dynogest group had a lower cost of treatment. So they could not say that pregnancy outcomes were better, ovarian stimulation was better. There was no statistical difference between anything, except this, that the cost of Dynogest was lower than that of GnRH agonist prolonged suppression. Having said that, again, Dynogest, why I'm bringing Dynogest so much over here, because we feel it's very easy to use a drug like Dynogest. We would much rather use Dynogest rather than the ultra-long GnRH agonist protocol. But then there are so many studies which show that it may not be a great protocol of changing from the ultra-long study to Dynogest. This is again coming from a Japanese group, and they have used Dynogest as PPOS. That is progesterone primed ovarian stimulation. So here Dynogest is not being used for anything else. DNG is an effective progestin. Now, I brought this only to say that like I use medroxyprogesterone acetate. A lot of people use Dufaston. Same way, even Dynogest can be used for PPOS protocol for IVF in women who have endometriosis. But, and there is very little exacerbation of endometriosis, and we do get good quality frozen embryos. So all I'm saying is that GnRH agonist long protocol for 3 to 6 months can be replaced with Dynogest, but you don't expect any miracles to happen with this drug because the results are almost the same, even inferior in some studies. The only thing is that if you're doing a PPOS protocol in an endometriosis patient, then instead of using medroxyprogesterone acetate or Dufaston, you can also use Dynogest. Having said that, I come to the continuous oral contraceptive use versus long-term pituitary desensitization. And let's see what this has to say. We all understand that IVF ICSI pre-treatment with continuously administered oral contraceptives may offer fewer side effects and lower indirect costs. So again, it is the cost on which everything boils down, that OCPs are so cheap that if we give them for 6 to 8 weeks, it would be much cheaper than the GnRH agonist, the depot GnRH agonist for 3 months. And we might do enough suppression in just 2 months. But the study is still not complete, and they are going to come out with results very soon. You can take this reference and probably we can find out what happens. Again, our RBMO publication, a comparison of 2 months pre-treatment with GnRH agonist with or without an aromatase inhibitor. And the conclusion is the combination of dipoleupride acetate monthly for 60 days combined with daily letrozole has a better clinical outcome at IVF in women with endometriosis than dipoleupride acetate treatment alone. Now, we all understand that dipoleupride for 2 months is not enough, and they've compared 2 months of dipoleupride alone and combined with letrozole. So I feel out of all these protocols, Dynogest, OCPs, we don't know how much they would suppress the bad effects of endometriosis, but maybe GnRH agonist with letrozole for 2 months might suppress endometriosis to an extent which might take away the bad effect of endometriosis from oocytes to some extent. So the ESHRI Endometriosis Guidelines 2022 says a specific protocol for ART in women with endometriosis cannot be recommended. Both antagonist and agonist protocols can be offered based on the patient's and physician's preferences, as no difference in pregnancy or live birth rate has been demonstrated. So this is very clear. You can use antagonist protocol, but make the cohort for the patient first, or you can use the long agonist protocol. The extended administration of GnRH agonist prior to ART treatment to improve live birth rate in infertile women with endometriosis is not recommended now, as the benefit is uncertain. So that what was told by Salim to us in the Cochrane review, which sort of caught upon with all us IVF specialists for the last 10, 12 years, is not recommended anymore, that do not give prolonged suppression because you will not be able to stimulate these ovaries. There is insufficient evidence to recommend prolonged administration of combined oral contraceptives, progestogens as pre-treatment to ART to increase live birth. So we still don't have enough evidence to say that oral contraceptives prolonged use or Dynogest prolonged use is a good pre-treatment. Maybe GnRH agonist ultra-long protocol with letrozole might have some value. Take-home message would be controlled ovarian stimulation for IVF in women with endometriosis is similar to those without endometriosis. The dose of gonadotropin and protocol depends on the age of the woman, the ovarian reserve, and the previous response to stimulation. Attention is now focusing on pre-treatment in women with high-stage endometriosis to reduce the pro-inflammatory detrimental effect of the disease on oocyte, embryo, and endometrium. The first drug used for this purpose was prolonged GnRH agonist, and all our attention is still on this drug to make it more effective in a shorter period of time without suppressing the ovary so much that we may not be able to recover oocytes. A plethora of new cost-effective and easy-to-administer drugs are being tried with the same aim of reducing proliferation, vascularization, and inflammation by endometriotic implants, thus its adverse effect on IVF outcomes. Thank you very much.
Thank you so much, ma'am.
Thank you, Dr. Thank you, Dr. Abha,
Thank you, ma'am.
for a very nice and crisp presentation. And the messages that you have given, I'll just present to the audience for that. Basically, endometriosis is affecting the ovaries and the endometrium, the implantation part. So the agonist or the antagonist protocols, as ma'am has very clearly defined, that it hardly matters. You have to go as you go for IVF stimulation. Adenomyosis part, what part has been affected? If it is the adenomyotic part, one can have it treated, pre-treatment with the Divagest, and then the implantation rate will be improved. The oocyte quality factors, the age and unilaterality or bilaterality, these factors will affect the significance of your stimulation. And the consultant has to see whether the pickup part is difficult. So pre-surgery is required before stimulation, or you can go for medical treatment. So ma'am has very precisely marked everything regarding endometriosis, ovarian stimulation and pickup and management. Thank you so much, ma'am, for your presentation. And it has cleared many doubts then what to do in what stage. Thank you so much, ma'am.
Now, I have only spoken on controlled ovarian stimulation. I have not brought the part of embryo transfer into it. And if the adenomyoma is big, if we feel that, the uterus is not fit for implantation at the moment, we always segment these cycles and freeze all embryos, reduce the adenomyoma, because I feel that more than endometriosis, adenomyoma is more detrimental to implantation. And nowadays, we like to bring the volume of the uterus to about 100 cubic centimeters. If you can calculate the volume of your uteruses, and it is 100 cubic centimeters or less with an adenomyoma, you are very lucky and you can go ahead straight away for an embryo transfer in it. But if it is larger, then giving GnRH agonist is really a very good option, because here stimulation has already been done. You've already frozen the embryos. All you have to do is just go on reducing the inflammatory response and the integrins of the endometrium, in these. And you can, people abroad in a lot of countries, Europe, they've used GnRH agonist for even 12 months with a little add-back therapy, only to go on reducing the adenomyoma. I'm doing it for a young 30-year-old girl whose volume of the uterus was 250. It has come down to almost 125 cc now, with about 8 months of Zoladex. So if it is diffuse adenomyosis, medical treatment is the best. But if it is focal adenomyosis, you can also resort to surgical treatment, but should be a very good surgical team who regularly removes adenomyomas and can approximate the uterus well, so that the risk of rupture of the uterus during a pregnancy should not be there.
Ma'am, what is your experience regarding the sandwich therapy? Like a patient who has got a borderline or a lower reserve, you do the pickup, and there is a significant factor of the adenomyosis or enlarged uterus also. So we are both ways, we are in the losing part. So we do the pickup and freeze the embryos and then reduce the size of the uterus and then transfer. So what is your experience? Does that do well?
See,
The
what
frozen
I've
embryo
seen
transfer.
is in very large uteruses, even 6, 8, 12 months of GnRH agonist doesn't help much. They land up, often if they get pregnant, land up in miscarriages also. I feel surgical reduction is a good option, but has to be done by very expert hands, has to be done in with a good team. So both ways, if it is not a very big adenomyoma and it is diffuse, then I like to give medical treatment. But if it is local large adenomyomas, and after giving 6 months of GnRH agonist, the uterus still has large adenomyomas, surgical treatment is best. We always freeze our embryos whenever there is adenomyoma, which sort of is haunting us. I don't transfer, but endometriosis doesn't have so much negative effect. It does reduce the implantation potential of the endometrium by reducing the alpha 5 and beta 3 integrins, or by reducing the HOXA10 receptors. Also, the hydrosalpings, which always accompanies these endometriotic cysts, are a result of not any infection in the tube. So we don't need to clip them always. I keep telling people, why are you taking them for clipping? They've already had a surgery. Again, this tubal fimbria has got stuck, and hence it is making the fluid is not escaping, and thus it is showing as hydrosalpings. So hydrosalpings of 10 millimeter or less should not, I think, in cases of endometriosis, not need treatment. And unilateral, again, don't need treatment. So we can just sit and relax. If you've made good embryos, they will overcome a hydrosalpings, which is not very significant.
Thank you for those wonderful practical tips, ma'am, because I think your experience with every sentence, whatever you tell us, matters. So what exactly for your PPOS, by your personal experience, ma'am, do you prefer MPA? Do you prefer dydrogesterone or letrozole? Now, what have you shifted on to?
I do a lot of medroxyprogesterone acetate, 10 milligrams. And I do it, all the donors use only this in our center. All the donors, no antagonist is used for them. So it keeps the cost also lower, and plus it is very happy for those donors, one injection a day. And for all our duostims, we use medroxyprogesterone. It again has advantage that there is no menstruation in the middle of the luteal phase stimulation, because meprate keeps the menstruation suppressed. We are giving progesterone, and we continue to give it as long as the stimulation continues. And we used to start our stimulation on day 3 also of having picked up the first cycle in dual stimulation. But now we've started delaying, because we realized by starting on day 3, we have to give 2 days of extra gonadotropins, which increase the cost. And by starting on day 5, those 2 days of gonadotropin reduces. So we use only medroxyprogesterone acetate in my center. I used to use that, and then everybody saw the convenience of this, and they saw that no cycle menstrual breakdown is happening. So our whole team now has switched over to only medroxyprogesterone, and it is the cheapest. Dufaston is still quite expensive.
Thank you.
Okay.
Over to Dr. Manju. Thank you so much, ma'am. Thank you, ma'am.
Thank you.
Thank you for your time, ma'am. Thank you for accepting. Thank you for always being there for us.
Thank you for having me over, trusting in my talks, and asking me to give a talk. Thank you.
Thank you.
Thank you, ma'am.
Over
Thank
to
you,
Dr.
Dr.
Manju.
Jyoti, for giving us a chance.
Yeah, thank you. Dr.
Thank
Manju.
you.
Okay, now we are after a very insightful and enlightening talk by the Dr. Abha. So we are next, we are moving ahead to the surgical management of endometriosis in infertility. It's a very important topic. For this, I would like to introduce our chairperson. First is Dr. Rimmi Singla. Madam is Director of Reliance Hospital and Test Tube Baby Center, Mohali, Punjab. And she's doing very good in her 30-year experience in infertility and lots of award and publication. And madam is very active in this field. And next, I would like to introduce Dr. Gurneesh Singh. And sir is head of the department, retired from the army and from the Agroha Medical College. And now sir is the president of ISAR Haryana Society, and heading his own Ellora IVF Center, Hisar. And next is Dr. Rachita Malik. She is Center Head Indira IVF Hisar. And our next is Dr. Reenu Chugh. She is the IVF specialist and past president of ISAR Haryana. And now I would like to request the chairperson to please introduce our esteemed speaker, Dr. Sandesh Kade.
So it's an honor that I'm getting to introduce Dr. Sandesh Kade, sir. He is Director of Advanced Gynecological Institute at Barjeel Medical City, Abu Dhabi. He is Head of Multidisciplinary Team for Endometriosis in collaboration with IFEMNDO Institute from France. He is the team member of the first uterine transplant of India and first laparoscopic uterine transplant of the world. So we are so honored to have him here with us so that he can enlighten us with his tips and tricks dealing with endometriosis during surgery. He is an expert laparoscopic surgeon at Bahrain International Hospital, Abu Dhabi, visiting endoscopic surgeon to the busiest IVF centers, FMC in UAE. He is also director and consultant at Solapur, visiting laparoscopic surgeon Kenya, Bangladesh, and Nigeria. He is faculty for TLS training workshop he has been faculty for and continuously being faculty for training workshops at Agra, Jodhpur, Jaipur, Hudal, Delhi, Jalandhar. Faculty for radical hysterectomy workshop at Galaxy Care Hospital, Pune, and is winner of best surgical videos at all the conferences that we have. So I welcome Dr. Sandesh sir to enlighten us with his wisdom and to help us understand the difficulties that we face during endometriotic surgeries. As we know in gynecology, the worst case anyone can get in surgery is endometriosis. So please, sir, take over and guide us. Thank you.
Thank you so much for those kind words. And I'm at the beginning. Let me actually apologize because my presentation is not opening on this computer. So I'm going to present is the surgical management of endometriosis. So basically, there are three types of endometriosis. One is the peritoneal endometriosis. Second is the ovarian endometriosis, that is the regular endometriomas that we find. And third is the DIE, that is the deep infiltrating endometriosis. Now, if you see world over, the endometriosis diagnosis takes 7 to 8 years. Now, what we have to read here in between the lines is that we are very poor in identifying endometriosis in the early stage. So we identify majority of the times endometriosis when the girl or that lady has a big endometrioma, and many people even confuse in that. Second, we have to understand that there are limitations in our patients performing MRI. And so again, we are not able to interpret and diagnose or to learn exactly the type of endometriosis. So there are different phenotypes of endometriosis. She could be just a case of peritoneal endometriosis. She could be just a case of ovarian endometriosis, or she could be a very severe deep infiltrating, wherein the commonest is the patients having bowel endometriosis or the parametrial endometriosis or the ureter or the renal involvements. So these are the limitations we have and we delay our patients. Now, there is no direct randomized control trial to tell us whether we should do surgery first or IVF first. Now we have to understand that not all patients of endometriosis need IVF. Because if you go to ASHRAE guidelines, see, there are different studies which based on which they have given us the ASHRAE guidelines. And these guidelines, they say that surgery is not required always. Okay. It is not required always to improve the fertility. But they have cautioned us that you should actually do surgeries when these patients are landing with pain. So now it is very important to understand which are these patients. So, but anywhere in the ASHRAE guideline, they have never said that you send all endometriosis patients for IVF. Okay. So there is a very good chance of surgery in patients. If you have an absolute indication that you have to do an IVF in these patients, then I agree. I do not debate here. But if you do not have an absolute indication to do an IVF, then why not try a surgery? A surgery which would reduce her pain, also improve her quality of life, and also improve her chances of natural conception, and also not reduce her ovarian reserve, and improve, in fact, her IVF results. So why not think of a surgery? And these are the patients we have to identify and find out. Now, I have seen and I have been participating in a lot of IVF conferences. And sometimes when I go to a IVF conference, I feel frightened to actually fight against them and tell them that there are patients who need surgery. Because now I will tell you that not all patients of infertility they present, or the endometriosis present with pain. Now, lot of IVF people do not know what is dysuria. Okay, now dysuria is a very catastrophical symptom of a patient. That means when the endometriosis affects the uterosacral ligament and the splanchnic nerves besides the uterosacral ligament, this lady is not able to evacuate her bladder, and she needs to use her abdominal muscles. She takes more time in the washroom to pass urine. So this is a very significant symptom for me. And this patient, forget your IVF, she first needs to do a surgery, because otherwise very soon she will lose her kidney, or she can go into a continuous lifelong self catheterization. So this is one of the indications. There are patients who will not have pain, but they will have only deep dyspareunia. Young patients who cannot have intercourse and sex, and they are labeled that you, okay, you have endometriosis, go for IVF. No, these patients need to be tackled by surgery. Their vaginal nodules have to be excised, and they should be made less painful, and then they can actually, maybe they are not a case of infertility. So another, that is deep dyspareunia. There are so many patients who come to us with bloating. Now, when you have a large tummy because of endometriosis, cyclical pain and bloating, then it could be a severe form of subocclusive bowel endometriosis. Then these patients need to be operated first. So what is happening, I'll tell you, is that everybody is correlating the infertility specialist, the IVF specialist, consider the laparoscopic surgeons as their worst enemy, because they have only one notion, that these people fry the ovaries. Okay, so it has been long now, almost 2009-10, that is 12 to 13 years, we have stopped doing cystectomy. The real problem is, and what has actually made me shift from India to here, is that majority, still today, majority of the centers in India, we do not have CO2 lasers, we do not have plasma, we do not have argon lasers, we do not have the sclerotherapy options, and that's why what we perform is only cystectomies. And when you have your tool, that is only the hammer, that is the cystectomy as your tool, you will find every ovary a nail, you will hammer it, you will do a cystectomy and reduce the egg reserve or the AMH. And it has been proved that the cysts do not have a cleavage plane. There is no histological cleavage plane. And whoever in the world, the best surgeon in the world, even if he does a cystectomy, there is going to be some ovarian loss. And so cystectomy, because we feel cystectomy is the only thing that is available, we perform almost 8 to 9 procedures on ovary. It would have been really good for me to have a presentation. Sure, I will share it with your Haryana group for everybody to understand.
Dr.
There are
Sandesh,
many
sir,
different
can
techniques.
I interrupt?
Yes.
If you would like to do your presentation, take 5-10 minutes. We can still wait,
No,
because we
actually,
would love to
no,
have.
I am with my presentation besides, but this one is not allowing me to open the Zoom. And the second computer through which I have borrowed and joined does not allow me to open the presentation. So I'm extremely
Okay.
sorry, but
Okay.
I would
No,
not
we
like
would
to
have
lose
loved to
this
see
chance.
your surgeries also,
And
no?
when you approached me that Dr. Abha madam is going to speak and be there, I said, at any cost I want to be there. So I'm extremely sorry for this presentation in a direct dialogue way. So
Right.
now
No, no.
see, when so what is it that you can perform? So now let us start with, there are three types, as I said. When you have, let us go one by one. Peritoneal endometriosis, or simple small tags of powder burn appearance or red implants somewhere in the peritoneum. So majority of us do laparoscopy. And whenever we have debate, the best way to answer a debate is to have a RCT. Okay, so in implants or the superficial endometriosis, do we have RCT? Yes, we have very good two RCTs. One is by Christopher Sutton and another is by Abbott. And these two RCTs have shown us that there is a good indication to excise or ablate these lesions, and it will improve the pain factor of these patients. Now, there are two other very good RCTs which have studied whether it improves the fertility. And these are by paparazzi and also by the Alborzi, the two articles. Now, if you see these two RCTs, they are contradictory. One RCT has shown that excising or ablating the superficial endometriosis improves fertility, while the other one did not show any change. Now, when you have two RCTs very close to each other, released very close to each other, and one saying yes, it does, the other saying I don't know, it has not shown. Okay, so what they did is they combined these two together, meta-analysis was done, and then when pooling all the patients in both the RCTs, they demonstrated that yes, excising is a better option. So anybody performing a diagnostic laparoscopy, it is always better in case of for infertility is to just upgrade your centers with a better equipments and be able to perform excision or ablation of the superficial endometriosis, because RCTs have shown it to improve the fertility. Now, this is one case, that is the peritoneal endometriosis. What about ovarian endometriosis? In ovarian endometriosis, we always try to take the help of AMH. That has become the regular fashion now. But AMH alone is not the complete science. Now, whenever I try to explain AMH and ovary, I ask you to understand or take into consideration a cherry tree. When you have a cherry blossom flowers, not all flowers will develop into buds. So there is, these flowers are the number of the eggs which are there in the ovary. So at present, these are very, very, very small eggs. Okay, so they are not the ones producing AMH. Out of these eggs, some are going to get recruited. So they are going to become buds. They are going to become green cherries. And then finally there would be a red cherry. So these green cherries are the ones that produce the AMH. Likewise, in ovary, AMH is representative of only these types of green cherries, the small grown up follicles which are coming into the cycle. But there are other reserves of eggs. And so AMH is a problem for IVF specialists and not regular infertility specialists or obstetrician gynecologists who we treat infertility patients. So for natural conceptions, spontaneous conceptions, low AMH is not a big hindrance as compared to IVF specialists. And yes, it has been shown that when you have very, very low AMH, yes, pregnancy rates are lower in IVF, but not in the spontaneous conceptions. So you have seen so many patients with low AMH. Do they suddenly become menopausal? They continue to have menses, they continue to ovulate, and what you need in a regular spontaneous conception is a single egg. So believe me, AMH alone should not be taken. So take ovarian volume, take antral follicular count also along with the AMH values. And the biggest problem AMH has created is the controversy or the rift between IVF specialists and laparoscopists. You do a pre-operative AMH, and suddenly post-operatively again they repeat it within 3 months, bound to get a low AMH level. But it has been shown you should not do a AMH post surgery in 3 months or 6 months. It takes at least 6 to 8 months to rise, and then of course it will not rise to the near normal or the previous one, but there is a significant rise in the AMH. If you do it immediately post surgery, there will be a lot of controversy and fear or fright amongst the patients. So do not use it in this way. until almost like a 6 to 8 months to 1 year. So that is another indication, I would say. Yes, I agree, and it has been shown, and we have really understood it long back, 10, 12 years back, that cystectomy is not to be performed in patients of infertility. So what we do is, based on the patient's indications, whether if she has completed her family and has ovarian endometrioma and pain, in those patients we perform cystectomy because it reduces the pain and it reduces the recurrence rate. But in infertility patients, the priority is to preserve eggs, and so we perform what is called as either ablation. Now, in ablation therapy, we have stopped or it is given up. There is a big no to bipolar coagulation. Bipolar coagulation should never be done in endometriosis surgery. So what you can do is laser CO2. So there a RCT? Yes, there is a big RCT and a good follow-up by Paku Carmona, and he has shown that laser CO2 is giving a very good results in preserving the fertility and pregnancy rates in patients as compared. Cystectomy has been compared in all these tests. Now, plasma therapy, does it have a RCT? No, plasma therapy does not have an RCT, but there are a lot of studies which have done. There has been a pooling of data. The center with we are affiliated, that is the IFIMENDO, have shared their data with the one with Dr. Bendifala in France, the Tinon Hospital, and they have done propensity scoring, and it has shown that yes, plasma therapy also is a very good option to perform in patients with ovarian endometrioma and not perform a cystectomy. Sclerotherapy, where do we do sclerotherapy? There was a era when sclerotherapy appeared, then it went off, and now again it is coming up. So especially when you have, it is known that when the ovarian size is very large, definitely there is going to be more ovarian reserve loss. So when you have very large ovarian endometriomas, 8 centimeters, 10 centimeters, these are the patients where you cannot do cystectomy, you cannot do plasma therapy, laser ablation over such a wide area. So in these patients, sclerotherapy is a good option to perform when the patient is wishing for a pregnancy. And thirdly, if the patient is not going for natural conception, there is an indication for her to perform clear-cut IVF, then we do not do any of these, neither the sclerotherapy or the plasma therapy or the CO2 laser. We directly perform what is just simple drainage and send it to our IVF specialist. They are good in their ovulation protocols as mentioned by Dr. Abha, and they can retrieve very good egg reserves. So let us not do harm by ourselves and then damage and send these patients. Very often, it was very easy that endometriosis patients, they would borrow the egg donation. But the place where I practice here, there is no egg donation allowed. So in these cases, we have to be very, very strict and conservative and preservative for the fertility preservation. That has to be our prime aim in these places where the egg donation or egg sharing is not allowed. So we have a lot of patients opting for such techniques which we regularly perform. And always we have a MDT. All our cases are discussed in a multidisciplinary team, and then we will fight against each other, and then only we come to an agreement which would preserve the fertility of these patients. So ovarian endometriomas, like I said, they will not be there in isolation. Very rarely a patient will have only ovarian endometrioma. The main culprit is the peritoneal endometriosis or the deep infiltrating endometriosis. And these lesions over the peritoneum or the uterosacrals, these are the places where the ovary goes and sticks, and then the ovulation happens, and these patients start producing the ovarian endometrioma. So very often you will always find when you perform the laparoscopic surgeries, the ovarian endometriomas break. they are bound to break in 80% of the cases because they are extra ovarian in 80% of the cases. So very rarely you have isolated ovarian endometriomas per se, but otherwise they are associated with peritoneal and deep infiltrating endometriosis. And like I said, the deep infiltrating endometriosis, we should not just go by saying that you don't have pain, or there can be asymptomatic patients, but very often we are doing patients with subocclusive. They come into our emergencies and we get a lot of reference from our ER team where the patient comes with bowel occlusion, and a lot of patients who have already had a colostomy for acute obstructions. So these patients should be operated before they actually land up into we this 6 months we have removed 4 kidneys. So you can imagine it is real. These pathologies, the kidney is called as the silent killer. These patients will not complain of pain. So I really don't know if this complete history is elicited, or the IVF specialists have that time to elicit all this history. So my whole idea or the conclusions in my presentations were that do not directly refute a patient of endometriosis that no, endometriosis means infertility and IVF. So always think what stage or what type of the endometriosis is this patient going through, and whether I should do an IVF or I should better take an opinion of a specialist and ask him that if I delay this patient by, and not all patients conceive in first month of IVF, first cycle. You need 3. So what is the pregnancy rate with IVF? It is almost like 43 to 68. Now 43 is in the first or to the 2 cycles, but in the last cycle, when you do 3 cycles of IVF, then you reach that figure of 60% or 68. But when you do surgeries, there are lots of papers, and one of the RCT, which is called as the Endor trial, ENDORE. This Endor trial is worth reading, and you will all see the primary aim was to find what is the functional outcome of a bowel deep infiltrating surgery, and the secondary outcome after 5 years was pregnancy, and they found that 81% pregnancy rates. Now I am not saying all patients, see 81 means majority of the patients in Endor trial became pregnant spontaneously. So that is the whole idea I'm trying to say, that not all patients need IVF. Lot of patients conceive by spontaneous methods. So what are the methods is by doing a good EFI, endometriosis fertility index. You see the tubes, you do a good clearance, good excision, relieve the pain, improve her quality, and then at least give 6 to 8 months of trial. And if the tubes are healthy, of course, if the tubes are damaged, then yes, there is no waiting. You can just refer the patient back to IVF. So this is the whole idea I was trying to tell in my presentation, is do not think all laparoscopy endometriosis surgeries are destroying the ovary. Not all patients have ovarian endometrioma, and not there are many deep infiltrating endometriosis patients should not be delayed and should be tackled by surgery to actually not just give a baby and lose a kidney, or have a colostomy and delay her prime time. So this was all that I wanted to share in my presentation, and if there are any more questions, I would be very happy to answer. 2 more points before I conclude. Usually I see that when you don't have slides, you miss so many points, is the complications. The biggest factor which could be asked is, but doctor, when you do such extensive surgeries, there is chance of complications. Now there are lots of studies, and there again are studies where they have pooled the complications all over the world, and then they have studied, and believe me, the complication rate is not more than 3%. So, but the complications are severe. There is a grading called as Clavian-Dindo classification, where grade 3, where the patient has to be readmitted, reoperated, the incidence is very low. And when they studied these complication patients also, and when they reached to them after 5 years, they found majority of these patients conceived and that too spontaneously. So we are just like one complication and we just stop doing all the surgeries. That is not the way. Go and ask the patients who have regular routine complications. Here, when we are doing every day the severe endometriosis cases, we cannot take a leave because we are knowing that every month we will have one or the other complication coming, and so that is less. It is up to 1 to 3%, but definitely it improves their quality of life and also saves a lot of vital organs for those patients. So recurrence rate, whenever the patient is not going for fertility, there is again a very good RCT to show about and talk about the recurrence rate. And this RCT is from Renato Seracoli, and he has shown that whenever you are not going for pregnancy, put these patients on simple oral contraceptive pills in a continuous fashion. If you do not put the patient on oral contraceptive pill in a continuous fashion, you increase the chance of recurrence by three folds, or there is a chance of 29 to 30% recurrence in the next 5 years. So if you put it if you put these patients on oral contraceptive pills, the incidence goes down to 2%. So you can imagine the importance and the significance of not leaving these patients well informed that what they have to do, how they have to change their lifestyle. And it is not just achieving a pregnancy or just going out of pain and then going back to our regular lifestyle. You have to really modify and give them a complete understanding of the disease and the progression. If suppose patients are without ovulation I mean without amenorrhea, and we have a study where the 43 patients were studied where did not have the amenorrhea, and in 1 year 43 patients when we studied, there was a significant progression of disease. And the significant progression was considered when we took 1 centimeter rise in the nodule size. So you can imagine it is such a big growth that can happen if you do not give oral contraceptive pills to these patients. So I hope I have covered a lot of topics, and if there are any queries, I would like to answer them in person. Thank you so much for this wonderful opportunity.
Dr. Renochuk, your comment. First, Dr. Renochuk's comment.
Dr.
Sandesh, Kade, I am highly fantastic presentation. It was, although we couldn't see, but the points are very clear. Yeah, only seeing your series, I was highly impressed. I was just okay.
Please.
You are a really great surgeon working at a very good place. So I think you can talk about all these things, but we in India, we don't have all the facilities, as you said. So we have to do many times, work under compromised circumstances. So that's why we want to avoid surgery. Very well said by you that, of course, patient should be given a fair chance to have natural pregnancy in endometriosis. That we as IVF specialist also we do the same. But surgery, I think as per your statement, as you said, that we should do, there is no doubt in DI. Deep endometriosis surgery is the best, no doubt. It will relieve the symptoms. But in mild endometriosis, I think small size of endometrioma, we can still wait and give a conservative treatment and then go ahead with IVF, in my opinion.
And Dr. Sandesh, thanks for a nice exhaustive lecture without slides. I have seen many of your videos of triple flap surgeries for adenomyomas and extensive surgeries. You are in Abu Dhabi where donor eggs are not allowed. Hence, isn't it like in India, if there is a borderline AMH, instead of doing these extensive surgeries, we can use donor eggs, or we can do minimal surgeries so that ovaries are easily accessible for the ovum pickup, and go ahead with IVF rather than doing extensive surgery for the deep endometriosis. Because after doing these surgeries like bowel resection and all, definitely will be delaying the treatment for 6 months or 1 year or more. And the second question was, I have started doing laser surgery now. along with in the laparoscopy, and with that you can easily do the ovarian dissection and prevent more damage. But do you do laser surgery even for the nodular excision in the bowels and etc. also?
For bowel nodule excision or bowel shaving or disc excision, we use regular harmonic, or these are the tools which we use. Plasma, we use it only exclusively now. We do not use jet plasma for surgical because we use it only for argon plasma, that is for the coagulation of the cyst walls. And the otherwise we have the either laparoscopic or robotic. Majority of us, the surgeries are now shifting towards, because these are very difficult and extensive. Robo, that becomes a very good, or especially when you have deep the sacral roots or the nerves involved, sciatica, backache, leg pain, radiating pain, these patients, we go with the robotic now. But it is correct. We really find sometimes very difficult to understand how these IVF guys are so expert and reach the ovary without actually damaging the rectum or the sigmoid, because it is like a frozen pelvis, and it is difficult to reach these ovaries without actually going through the bowel. And that's why we feel that, okay, a well done surgery, a well released ovary, a clean pelvis would actually be a better option, but provided you don't do any further damage to the ovaries. Thank you so much for this opportunity. Thank you.
Thank you, sir, for the wonderful talk. It was indeed a pleasure to have you here with us and listen to so many different things, as Dr. Jyoti said. And of course, it's a new thought process that you have introduced to us. And of course, thinking different is what we are, is we want to achieve this with these webinars. And we will definitely look forward to it, and we would like to see more of your videos and have you have your talks and videos more in our upcoming CMEs. So thank you so much, sir, for being here. Sir is
Now
here. Okay, I think he's here.
I think so.
Okay.
Okay. So thank you, Lakshmi. So now we are moving ahead to our next topic, our panel discussion on endometriosis. Now I invite Dr. Jatinder Chadha to introduce our moderator and our panelist. I think Madam is.
Yeah.
Dr.
So for this discussion,
we can skip this. We will skip this. We come on to the next slide, please.
Okay.
So
okay.
our,
Everyone knows Jyoti so well.
We can
So,
start the panel directly.
So I would invite Dr. Lakshmi Goel. She's an IVF consultant. Dr. Jyoti, IVF consultant at Cloud9 Fertility Hospital, Faridabad. And next slide, please. Dr. Jyoti Gupta. She is a diploma in clinical assisted reproductive techniques, fellowship in minimal invasive gynae surgeries, and Dr. Ishika Nayan, she's a surgeon and senior consultant, Sapra Hospital, Hisar. Dr. Anu Sharma, she's a senior consultant and administrative head, Kant Multispecialty Hospital, Faridabad. Dr. Divya Kumar, she is a fellow in ART and FICOG. Her areas of interest are assisted ART, gynae endoscopy, gynae sonography, and high-risk pregnancy. She's working, it has been mentioned in the slide, I'm sorry. Dr. Anupma Sethi Arora. She is an endoscopic surgeon based at Sonipat, Tulip Hospital. Next. Dr. Niharika Sharma. She is a senior consultant and center head, Neelkant IVF, Faridabad. Dr. Manju Dagar. She is director, Nestling Gynae and Fertility Center. And Dr. Meenu Handa, she is a IVF consultant, clinical director and unit head, Cloud9 Hospital, Golf Course Road, Gurgaon.
Thank you so much. Thank you, Dr. Jatinder. Thank you for introducing our panelists.
Sorry, I was a bit crisp.
Yeah,
But I think we should spend more time on
by
discussing the
6:15. We have, I think, 20 and 15, 35 minutes. So we'll do 5 minutes per case. Coming on to our panel on endometriosis case-based approach. So what are the 7 Ds that Sir was talking of? It is dysmenorrhea, dyspareunia, dysuria, dysgeusia, dysfunctional uterine bleeding, difficulty in conception, and diffuse abdominal pain. So any of these symptoms could present in a case of endometriosis. So we should remember, and mostly as I think Dr. Abha suggested, that it takes a lot of time by the time you come to a diagnosis in case of endometriosis, and somewhere around 7-8 years down the line, you lose while you keep on suspecting about the endometriosis, especially in young women, especially in our adolescents, and though in infertile women, you make a suspective diagnosis, and nearly 50% of these cases you can actually diagnose on laparoscopy. So the 7 Ds, again, the dysmenorrhea, dyspareunia and all. So any patient presenting with any such symptom, we should be careful. And does early diagnosis versus a late diagnosis lead to a better quality of life? Now, actually, my slides are skipping. Now, the GDG recommends that in symptomatic women, attempts should be made to relieve the symptoms, either via empirical treatment or by diagnosing the disease. So we come on to our first case. Dr. Ishika is there. Dr. Ishika, we have this 16-year-old girl who has attained menarche at age of 13. She complains of severe dysmenorrhea with frequent absenteeism from school and interfering with the daily activities. So it has been happening for over last 6 to 8 months now. Her menstrual history is a regular 5 to 6 days, 28-30 days regular cycle with an average flow, but with severe dysmenorrhea and a partial relief with tablet meftal-spas. Now, asking her medical, the family history, the mother also attained in menarche at 12 years with a mild dysmenorrhea, and sister is 10 years old. So we would like to manage her by doing her ultrasound, by doing a blood test, and we would like to treat her. Now, on her ultrasound, when we did her ultrasound, we saw that the uterus is normal size, the endometrium is 6.8, myometrium is homogeneous. The left ovary has a 4.5 centimeter cystic lesion with internal ecos, and the right ovary has 2.5 centimeter cystic lesion with internal ecos. So what is your diagnosis, and what is the best treatment for these adolescents?
Ma'am, as she is having severe dysmenorrhea and the ultrasound is clearly showing ovarian cyst with the front glass appearance, it is probably endometriosis. We can confirm endometriosis with various modalities, especially in adolescent. We can go for an MRI pelvis. But the gold standard is definitely diagnostic laparoscopy, but it is done in the cases in which even after starting a conservative treatment, the patient is not relieved. So suspecting endometriosis diagnosis in an adolescent, we can start her on conservative treatment like oral contraceptive pills or progesterone only, like Divagest and progestins. We can also give her DMPA after she have achieved the age of 18 years. At 16 years of age, you cannot start DMPA. And if the endometrioma is big, like one is a 4.5 centimeter, if on serial ultrasound, we see that the endometrioma is growing and she is having severe pain, or there is a severe symptoms like dysuria, dyschezia, you can go for surgical management, and we should not delay surgical management in adolescent patients just for the sake of saving fertility, or like she is unmarried right now. So in these cases also we can go for laparoscopy.
Okay, so definitely, very rightly said, Dr. Ishika. So diagnostic procedure would, for what your first diagnostic procedure would be, or you would straight away go in for a
First is
MRI?
ma'am, we have to do a ultrasound. You said that in ultrasound there are you can see there are bilateral cysts present. We can diagnose using MRI pelvis. We should go for a CA-125 also, because in CA-125 we can easily follow up in later on if the CA-125 is raised. After surgery also we can go for serial CA-125, and AMH should also be done in these cases. And in cases of chronic or acyclic pelvic pain. Yes, ma'am.
Yeah. So in adolescence, a very careful history has to be taken. Like we have to focus on a family history, a positive family history, a history of early menarche, a history of short cycles. So these are very, very important. Then we also have to obstructive malformations. In those cases also, there is a lot of cases who come with endometriosis. So
end up in
adolescence, it is a very, very strong recommendation to take a very careful history. And also these girls who are frequently coming, who are frequently absent from their schools, or with the use of oral contraceptives for the treatment of dysmenorrhea, these also we can sort of start thinking on the terms of endometriosis. Now, this is another very strong recommendation based on your history is all those symptoms of chronic acyclic pelvic pain, nausea, dysmenorrhea, dyschezia, dysuria, dyspareunia, or a cyclic pelvic pain. So any history suggestive of all these definitely gives us a clue to diagnosing of endometriosis. Now, what is these with severe dysmenorrhea or endometriosis associated pain? The clinicians should prescribe hormonal contraceptives, as Dr. Ishika suggested, or even progestogens systemically or via LNG-IUS, as the LNG-IUS, I think, again, is a little difficult thing here that we can, I mean, that would be thinking of in cases of adolescent, because putting in an LNG-IUS in an adolescent is something very, very difficult and would not be the first line treatment, where we can give them a hormonal contraceptive or progestogens or Divagest. So, however, it is important to note that some of them may decrease bone mineral density. And in adolescents with laparoscopically confirmed endometriosis and pain, in whom the hormonal contraceptives or progesterones have failed, the clinicians may prescribe GnRH agonists for up to a year, as they are effective when combined with the add-back therapy. So management, definitely, as Dr. Ishika suggested, the first line, NSAIDs and COCs if the NSAIDs alone do not work. And we definitely have to treat them symptomatically. And these are the two things that NSAIDs or other analgesics can reduce the pain associated with endometriosis. Combined oral contraceptives can be considered to reduce EAPP and for lighter periods. But in these cases, a continuous use is suggested so that there is less of withdrawal bleed. Now, progestins as the first line of therapy, Divagest or MPA or NEA are recommended to reduce this pain. And significant relief of pain has been seen with these progestins. And Divagest is as effective as agonist, but with less side effects. And it is safe for long-term use in patients with or without surgery. So coming on over to Dr. Lakshmi.
Thank you, Dr. Jyoti. Very rightly said. I think in the first case, it was very important to point out that obstructive malformations, uterine malformations must be ruled out in all the adolescent endometriosis. That's the take-home message. So we can, the MRI is very important. Also, we can go for a 3D ultrasound if required, if we suspect a genital malformation. And LNG-IUS, the point, just because it's an ESHRE guideline, which is the latest 2022 ESHRE guidelines. In US as well as in Europe, they consider LNG-IUS as a first-line modality for the treatment of endometriosis, even in adolescent endometriosis. Though in India, we do not prefer using a LNG-IUS as the first-line therapy, but there it has been used as a they are using as a first-line therapy. So we have put in there, right? So I think next, let's move on to our next case. Dr. Jyoti Gupta is not here, so Dr. Anupama, is she there? So let's move on to the next case. Dr. Anupama is here. So let's discuss the next case. She's a 25-year-old female with pain abdomen during periods for 6 to 9 months. She's married since 1 year. She complains of heaviness in lower abdomen. Her menstrual history is that she has regular periods, 30 days, 4 days flow. And she has severe dysmenorrhea, and there is no relief with NSAIDs. There is no past history. On investigation, in ultrasound, the uterus is normal size. Myometrium is homogeneous. ET is 6.5 mm. She has a left side adnexal mass of 12 centimeter with internal echoes with no internal vascularity, with pericystic flow. CA125 is 46. The HCG is 1.2 and alpha fetoprotein is 10 milligram per ml. So how will, Dr. Divya, how will you manage this young girl?
So the size of the cyst is fairly large. It's a 12 centimeter. It's a 12 centimeter cyst, I suppose.
Yes.
And she's young, she's married, she's having dysmenorrhea, and most of the tumor markers has been done. Other than like CA125 was little raised, I suppose. Rest of them were within marginally raised, yeah, and rest of the other markers were within normal limits. So but still, because the size is so large, so I will just like to add few more tests. I will get her tested for her ovarian reserve as well. I will do TVS for the other ovary if TVS has not been done, and then maybe I will like to do AMH as well. We have discussed discussed at length about AMH, but definitely I like to see her AMH and all. And then definitely the first thing, as far as management is concerned, it comes to my mind will be going for a laparoscopy for her, because the cyst is fairly large. Yeah.
Yes.
So that is how the first thing it will. But then definitely I like to counsel, and I'll like to do a husband semen analysis as well, because she's married and she's 25. Though like in mid-20s, fertility is on peak. So I will not like to waste so much of time. And side by side, I'll try to counsel them to get ready for parenthood also, both of them, in a subtle manner. Because see, there's so many things, like so many women or couple, they not like to plan a pregnancy immediately after marriage. But then since I will be suspecting endometrioma or endometriosis, then definitely I like to counsel them side by side and doing my workup. But then laparoscopy is definitely will be the first choice of management in this case.
So anything in particular in laparoscopy you will take care of, or you will have previous precautions, or anything in particular you would like to think before going in for the laparoscopy?
Laparoscopy, definitely I'll see on I will like to go, like this scan was done on what day of her cycle? I like to know that.
Scan was done post-myth, not day 2 of the cycle.
Day 2 of the cycle.
Right.
So I will just like to tell them about the recurrence of the disease, the nature of the disease, and
yes,
laparoscopy.
Right.
And definitely I'll try to avoid during the menstrual phase. I will just like her menses to be over, because once we do a laparoscopy in a menstrual period, during the menstrual period, the recurrence is very high. So I like to avoid that. I will tell them about the recurrence of the disease, and I will always tell them that doing a laparoscopy doesn't mean I'm going to this is going to cure your disease. You will definitely end up having another endometrioma in course of time. And I will definitely as I told you in the beginning, like I'll definitely tell them, encourage them to plan a pregnancy immediately after after the surgery is over. They should not be like wasting so much of time if they are anyhow they are going to plan a pregnancy.
So
And
during
other thing, like I will like, sorry.
no, continue.
And as far as like all the things, all the steps we follow, like minimal manipulation, but then I will definitely like to go for a cystectomy if the endometrioma is this large. I will not like to puncture the ovary and then come anyhow, because at 25 I am expecting a good reserve for her. The AFC and AMH, I'm just expecting a good ovarian reserve at the age of 25. So I will like to take the whole of the cyst wall out. I will not just go with the aspiration of the cyst technique. I will like to take out the whole of the endometrioma. Anyway, I am hoping the other ovary is fine, and I might get a good eggs from that ovary. I will go for a tube test also, chromoperturbation also, because though this larger cyst falls into endometriosis grade 4, but definitely if the other tube is healthy and there are no endometrioma on the other side and the tubo-ovarian relation is maintained, then I might end up trying simpler methods like IUI and all in her if she's ready for conception. And if that these are the things I will like to
Right.
consider while going for a surgery.
Yes, exactly. So we have this endometriosis fertility index surgery form, which is a very
Yeah.
helpful guide. Whenever we are taking the patient for surgery for endometriosis, we can take these things into
The scoring,
consideration.
yeah.
Yes, and then we can do a scoring. So endometriosis fertility index include a least functional score at the conclusion of the surgery, in which we can score the fallopian tubes, the fimbria, and the ovary, depending upon the function. So 0 will be the absent or non-functional ovary, fimbria, or fallopian tube. 1 will be severe dysfunction. 2 will be the moderate dysfunction. 3 will be the mild dysfunction, and 4 is normal ovary. So we can see these things in the surgery, as well as we see the historical factors like the age of the patient. If the age is less than 35 or equal to 35, we'll give 2 points. If age is 36 to 39, if age is more than 40, and years of infertility, if there is any prior pregnancy, and also the AFS endometriosis, the revised ASRM scoring that we used to use. This is the revised, this is the recent scoring system, which has been endorsed by ESHRE also. And in this, if they say that the EFI score is 0 to 3, then the period of the chances of conception at the end of 3 months after laparoscopy is very less than 10%. If the endometriosis fertility index is 9 to 10, which is a very good score, so the chances of patient getting pregnant is very high, up to 80%. So because in this young girl, she's 25, she's been married since 1 year, she might not want to conceive immediately. So we can score her and give her the chances of her pregnancy, how much there are chances in the next 3 years. And then we can go for the counseling accordingly, and so that she is prepared for all the things if she has to go for the IVF or IUI or medical management. So accordingly, we can counsel her and she can plan that. So these are the descriptive terms for the least functional that we had used in the scoring system. The tubes, if they are mild, moderate, severe, or non-functional, how will we describe it? These are the different terms which are in the guidelines. And these are the few pictures that we can see In A part, box A, we can see this ovary is normal. In B box, we can see this ovary will score it as 2 because there is a high endometrioma which has been cleanly resected, good volume of ovary remaining. So it will be scored as 2. C is the tube, we can see it will be scored as 2 because there is a distal tubal endometriosis. And in D part, as we can see, the fimbria is seen, which will be scored 2. And in E part, the ovary, we can see a very small ovary. So the small ovary will be scored 2 with low. It is a low volume ovary. Similarly, we can see the scoring system, and we can score after every laparoscopy case and give the patient their chances of getting pregnant at the end of the surgery within 3 years. So as we had already discussed, we'll go for the MRI and then we'll go for a laparoscopy with a good counseling and also tell her about her ovarian reserve in future. Yeah, so this has already been discussed. Then over to Dr. Jyoti for the next case.
Yeah. So EFI, as Dr. Lakshmi suggested, is a very good tool and it should be frequently used because we just do a laparoscopy and we just start thinking of putting her on infertility treatment, whatever maybe. So we have to wait and watch, and depending on our EFI score, if it is, we have to weigh and balance whether she needs a conservative management, she needs a ART immediately. So that is very important. So coming on to this third case, 28-year-old, Dr. Anu is there, no? Dr.
Yes,
Anu, this is for you.
Yes, ma'am.
So she's 28 years, married for 4 years. She has been trying to conceive for last 1 year. Her menstrual history is regular, 4-5 days, 28-30 days. But she has dysuria and dyschezia. And she has received 2 to 3 cycles of clomiphene. Next, please. So on investigations, everything is normal. Her LH, FSH, TSH is normal. Her AMH is marginally okay too. And on ultrasound, she has a unilocular cyst 4 centimeter on the right side and has tenderness. Next, please. So how would you like to manage this case?
Ma'am, I would like to counsel this patient for IUI as well as consideration this patient a male factor also because as well as semen analysis is okay. I will counsel this patient for IUI with ovulation induction as well because this patient has better pregnancy rates with IUI.
So twice we have given her clomiphene citrate. So I think those now you would like to give another ovulation induction.
This time, ma'am, I will counsel this patient ovulation induction with gonadotropins preferably.
Okay. So laparohysteroscopy as has been suggested in the management. When would you go for a laparohysteroscopy? Or you would like to do a HSG only just now and go for a laparohystro later, or you would like to go just now and tackle the endometriosis as well and then go in for IUI? What would your management would be? How would you go?
Ma'am, USG is suggesting that 4 centimeter cyst. So, ma'am, we can plan laparohystro with the chromoperturbation, then after IUI with gonadotropins as well.
Okay, so hormonal treatment for suppression. This is a very important line here written that for cases of infertility, a hormonal treatment for suppression of ovulation is not indicated. And these women with stage 1 and 2 endometriosis should be treated with COH IUI for better pregnancy rates. Next, please. So, our medical therapy. So in actually, as I've suggested that our medical therapy effective as an adjunct to surgical therapy, and are hormones or medical therapy effective for these treatment of endometriosis associated infertility? What do you say, Dr. Anu?
I think no, ma'am.
Yes, exactly. So that is very clear there is no recommendation. There is no, it is a strong recommendation against medical therapy. So it is not recommended to prescribe pre-op hormone treatment to improve the immediate outcome of surgery for pain in women with endometriosis. And they may be offered post-op hormone treatment to improve the outcome of surgery for pain if not desiring immediate pregnancy. So only if we are only looking for these women with pain, we should be giving a medical therapy so as to prevent recurrence. So as long as immediately after surgery we put them on long-term COCs, the risk of recurrence decreases. But if we are dealing with an infertile woman for whom we have done a surgery, there is no role of a medical therapy. And in infertile with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility. And with the whole purpose, the women seeking pregnancy should not be prescribed post-op hormone suppression with the sole purpose to enhance future pregnancies. And those who cannot attempt or decide whether they need to go in for a immediate treatment of their fertility, they can be sort of offered hormone treatment. And the clinicians here, strong recommendation should not prescribe pentoxifylline or in other anti-inflammatory drugs or letrozole outside ovulation induction to improve the pregnancy rates. So, and for Dr. Lakshmi,
I want to add one thing, ma'am. The patient has dysuria and dysphagia. What about that? How will we treat that?
So first, if the patient has pain, then definitely that has to be treated first, and then we think of infertility. So if she has a lot of dysuria, so we definitely have to now come in and rope in a surgeon. Or we have to go into
cystoscopy for that, along with the laparoscopy. Cystoscopy along with the laparoscopy is the line of the management in these patients.
As Dr. Sandesh had referred, that this dysuria and dysphagia can be due to the endometriotic nodules in the peritoneum. So while laparoscopy, we can take care of them. We can fulgurate those nodules, the nodules on the uterosacrals or on the bladder flap, and then maybe her symptoms get relieved.
If we are doing the laparoscopy, there is no harm doing the cystoscopy side by side.
It is always a good idea also, because cystoscopy doesn't take much. It just takes another 3 minutes more. Along with the operative laparoscopy, one can also put in a cystoscope, assess the inside of the bladder, and then accordingly treat that patient that way. So cystoscopy also is not a bad idea. And as Dr. Lakshmi suggested, that these cases definitely need a laparoscopic operative treatment only. I mean, then later on we may put them on other infertility drugs, but the primary aim would be to treat the pain first and then treat the infertility.
Right.
Also, can I add a point, Dr. Jyoti?
Yes, please.
The size of the cyst doesn't indicate the stage of the disease.
Right.
So one should never be in a misconception that the size is small. Or small size cyst patient may have a grade 4 endometriosis, and that may be the cause of all pain. So whenever patient is presenting with pain and is symptomatic, laparoscopy is the first thing to know the staging of the disease.
Actually, sometimes big endometriomas we just encounter. Otherwise, they don't come with pain. And sometimes so many girls, we do everything, we see everything, the ultrasound is normal, and they come with such severe dysmenorrhea. So the size never matters, and it could be just, we have to first focus on their pain. So you're very right, Dr. Jatinder. So coming on to our next case, Dr. Lakshmi.
Yes. So this is for Dr. Divya. This is a 30-year-old female. She's married since 4 years. She complains of infertility and severe dysmenorrhea. A repeated ultrasound suggestive of right ovarian cyst, which is 4 centimeters, suggestive of endometrioma. She has received OCPs multiple times before, and now she wants to conceive. She is very desirous of pregnancy, and she has received ovulation induction with oral ovulations 4 times and control ovarian hyperstimulation with IUI 2 times. Her AMH is 1.2, her tubal patency test and HSA is normal. So how will you manage this case? What will be the counseling is required in this particular patient?
See, she is like 30 years old and her she has tried enough with all the simpler modalities like ovulation induction, even underwent IUI twice. And her AMH is like 1.2, which I'll say is like borderline only. And there's an endometrioma as well, which is like 4 centimeters. So in this case, counseling is definitely, because the patient must be very anxious, very much stressed, because once she's trying, it's not like she's been trying for 1 year. For one, she has been trying for, like, you can say, like, for whole 12 cycles she has tried. And once the patients, we all know how they how much distress they are into, like every cycle fails and they are like in tears, and you will have like 45 minutes of counseling in your OPD with such patients. So she definitely needs counseling, and this is one thing which this is how I counsel my patients when the tubes are patent. Because one thing we all have noticed in endometriosis, most of the time the tubes are patent but they are not working. So this is how I think I will start my counseling, though the tubes are patent but they're not working. So not all tubes which are patent they are going to work. There are two different aspects. The tubes can be patent and working, but the tube is, though the tube is patent but it's not working. So in her case I'm going to start my counseling with this, because since she had gone underwent an HSD, she's like कि मेरे ट्यूब तो खुले हैं, फिर क्यों नहीं काम कर रहे हैं. मतलब खुले, मतलब काम तो करने चाहिए थे. But that is how I'll tell her that अगर काम करने चाहिए तो we have given enough, enough time for your tubes to prove, but they didn't prove. Like ovulation induction is one way we give a chance to the tubes to prove on its own. Then coming to it's like IUI, the proofs didn't the tubes didn't prove that they are like working. So we have to skip up, we have to like step up our treatment. And definitely for these patients, IVF or rather ICSI will be my treatment of choice, because sometimes the in IVF also we don't get the desired result because of the luteinization of the outer zone of the eggs becomes little harder. So ICSI is a better modality. And definitely I will be little scared of that 4 centimeter endometrioma, but then I will definitely do a TVS on my own, just to plan how to do my ovum pickup, whether I'll be able to retrieve the follicles without pricking the endometrioma on that side. The other side seems to be okay as for the like history which I have got. So this is definitely, this will be the one thing in the mind. But definitely whatever the site of the endometrioma is, I will like to counsel the patient again according to that, because 1.2 AMH is little alarming for me. Though I will definitely like to match it with FSH, LH, and AMH, and obviously ovarian volume, the other ovary, not the ovary with an endometrioma. That volume, that volume is not going to be the true volume. So these are the things definitely I like to keep in mind, and I'll like to proceed accordingly.
So would you want to go for a surgery, for a laparoscopy before or after? What will you decide? How will you decide whether you want to go for laparoscopy? In this case,
After ovum pickup and freezing the embryo, I might go for a laparoscopy, but definitely not before, as per the history. That too I might, because once I do the pickup, I'll have a fair idea. But I will have to counsel her for both. If things are okay, I might, but then depending upon how bad is the picture, I might freeze all her embryo and then go for a laparoscopy, clean it, and then go for my transfer.
So basically, you mean to say if there is a hydrosalpinx, then you would want to go for a laparoscopy, right? Clean it.
Yeah, hydrosalpinx, then definitely I'll have to clip the hydrosalpinx, and then I will have to go for embryo transfer. No second thoughts about it.
Yes, the ASHRAE recommendations recommend that if we have if we think that will be difficulty in ovum pickup or in the accessibility of the follicle,
then also
yes, we can plan the surgery beforehand.
Plan a laparoscopy before.
Yes, yes. So otherwise, there is no recommendation that going for a laparoscopy before to increase the
Is a
pregnancy rate.
mandatory thing. Yeah.
For before
Increases the pregnancy rate, right?
But ma'am, in my center, from where I did my fellowship, there was I have seen a lot of 9 to 10 patients I have seen with such a big endometrium, maybe 6 to 7 centimeters also. In that, my mentor, under which I did my fellowship, he used to do the only one single needle pricker, ultrasound guided cyst aspiration, especially in case of endometrioma, put her on agonist, and then after 2-3 months of giving the agonist, then they start the COH. Patient to be taken
That's a
for
very,
IV.
very valid thing, because the recent recommendation says that it will not increase the pregnancy rate.
No, not for the pregnancy rate, for the ease of doing the ovum pickup.
No, that's absolutely not recommended. See, the ASHRAE guidelines say that,
Yeah.
Clinicians should not prescribe ovarian suppression treatment to improve the fertility, because it will even more suppress the ovarian reserve.
That's true. We would, in that case, we would have to start the little on the higher dose, HMG maybe 450 or 375 in a lean thin patient, because the ovaries are already so down-regulated. But to reduce the size of the endometrioma, to aspirate the endometrioma, to make the oocyte pickup better, ovum become better. So
Not always the endometrioma would
But
come
it
with
has
not
it has
always
aspiration as a very high
yeah,
thing for
that's true, ma'am. But
osteoporosis also.
yeah, ma'am. Yeah, ma'am. But in my this thing, 2 years of fellowship, I have not seen any case of this oophorytis. But then usually I don't also do. Many people don't
But
do.
the evidence doesn't support this
Yes,
actually.
So
the evidence doesn't support
That's
this.
see
only
we have
thing
to
is,
follow something.
yeah, so see, only indication is when it is coming in the way
Yeah.
of pickup,
Way.
then it needs to be
Accessibility. Not
operated.
always does it
Otherwise,
come.
always it doesn't come.
Not
Most of the
most
time
of
it
the time,
doesn't
yeah,
come.
you are able to find a way, like here, there you will be
Yeah.
able to do it. And
And
moreover,
whenever,
in the present scenario, yeah, when there is
yeah,
one ovary is okay. So even if you are getting 8-10 from one ovary, you are quite happy कि चलो हो जाएगा काम हमारा.
Yes, we can even leave 1 or 2 follicles if we like.
Yes,
not
which
want to
we
cultivate
can't reach. Yeah.
endometrioma.
yeah, and whenever these cases, suppose we prick it, we first have to give a good post-op
Good
antibiotics
antibiotic, yeah.
and
Robust
change the
antibiotics,
needle
yeah.
also if if by mistake we
yes.
went through that, and using, I think, povidone also for the vaginal preparation in
We
cases
do
of
not see any
enormous.
abscesses forming. We do not encounter any abnormal,
Yeah.
any complications most of the times. What do you see, Dr. Jyoti?
Yeah, absolutely. So
Right.
it is always only if it is coming in the way or if it is causing pain. These are the only two indications where these need to be operated. Otherwise, they have to be managed. I mean, we do our inductions, we do our whatever ART, IVF, and then later on deal with them in case once we have our embryos ready, we have kept our embryos frozen, and then like Dr. Abha was suggesting that later on you can suppress them, do surgery,
You
and
can
then do
operate
an
them, yeah.
embryo. Yeah. So I think another 5 minutes. We are already 6:20.
Yes.
Last case for Dr. Niharika only.
Yes, ma'am.
Yes.
So
Dr. Niharika, we have a sorry, Dr. Jyoti, you carry on.
yeah, so we have this last case for you. She is 29-year-old, married for 1 year, complains of severe dysmenorrhea, dyspareunia, and on ultrasound, she has bilateral endometriomas, 2 by 3 centimeter. But her look at the AMH 0.9. And so how would you counsel her? And what is in your mind? How would you plan her treatment?
Ma'am, the patient is going to be nearly 30 and she's married since 1 year. And in spite of having, suppose she didn't use any or contraceptive or what, she is not able to conceive. So she is like, and AMH is 0.9. That itself indicates that we have to hasten up her family, counsel her to get the fertility, to get the parenthood as soon as the possible. But the main thing in this is the patient is having severe dysmenorrhea, menorrhea and dyspareunia. This it indicates some form of extra ovarian endometriosis that can only be diagnosed by doing the laparoscopy. So I would like to do laparoscopy in this patient firstly to diagnose the extent and severity of the disease outside the ovary. Though the ovary is showing the bilateral endometrioma, but the specific dyspareunia indicates some form of rectovaginal endometriosis or POD endometriosis or some endometric implants which is causing her so much of dyspareunia. So in the and side by side to rule out also, I would like to I would ask the husband to get the semen analysis done. In laparoscopy, I will assess the condition of the tubes and the uterus. First of all, I'll see all the broad ligaments and the uterocervical ligament, evidence of the endometriosis outside the ovary, whether and extent of endometriosis in the rectovaginal septum and the fixation of the uterus. So, and to see the condition of the tubes, whether they are open, tubo-ovarian
Now
relationship
with low AMH, you are what do you plan after doing the surgery? What are you gaining out of it?
Ma'am,
Or
AMH
you would
is
like to straight away go in for ART and do her pickup, freeze her oocytes or embryos, because her AMH is already 0.9.
0.9 AMH is low, but I haven't I will deal with the endometrioma also. I will not do the cystectomy. I'll just aspirate the endometriotic cyst and the drainage and just little internal wall vaporization of the cyst wall so that the recurrence won't happen. And side by side, we'll assess the condition of the tubes, whether they are open, the tube-ovarian relationship maintained or not. And after the surgery, I will plan accordingly, according to the condition of the tubes, whether they are open or not. If the tubes are okay, and they are I have cleared most of the endometriosis, the staging will be done after the laparoscopy, whether she is fitting into mild to minimal to mild endometriosis or she is going into moderate to severe disease. That can only be assessed after doing the laparoscopic surgery. If she is tubes are open and she can be tried with the COS with IUI with for 3 to 4 cycles. And then later on, maybe if she's not able to conceive even with COS and IUI, she can be taken for IVF, but not straightly for IVF depending on the AMH. Many a times patient do conceive after the clearance of the disease, and maybe IUI also we can offer her fertile period also after doing the surgery. And after 2 months of giving the fertile period, then also I can offer her IUI.
Yeah, so Dr. Niharika, I think you are right in a way, because she's only married for a year and she's 30 years. The only thing which is scaring us is her low AMH and the endometriomas bilateral. So maybe by doing this, just doing a laparoscopy, a diagnostic, and a little bit of therapeutic operative surgery for her, maybe we are still gaining time, and also maybe we are in the meantime trying a COS, and also trying, because though the AMH is low, maybe the oocyte quality may be still good because age is at her side. But maybe on the other side, maybe some of the panelists might like to differ. So anybody else has any other opinion?
No, I think I will like to assess her antral follicles once, but then with 0.9 AMH, I will definitely not like to waste time. I will counsel her for IVF only, and maybe I like to give her like 4 to 6 weeks of DHEA or something, because definitely she's young. She's young and this AMH is definitely not matching with her age. But endometriosis is there, and we all know that endometriosis causes early depletion of follicles. So I will definitely not like to waste time. I will like to go for IVF. I will like to counsel her, and then I will like to counsel her in a way that she straight away goes for the most advanced procedure, that is IVF FOGSI. So that is
Yeah.
all is there in my mind.
So, if like we can even go for a fertility free preservation, like we can freeze her
Yeah.
embryo. We can and then
Yeah,
we
we
can
can
go for
do
a
that, but
laparoscopy.
at least make her embryos, extract all the eggs, make
Then we
embryos.
can go for
We
a
can freeze.
laparoscopy, because straight away going for a laparoscopy can decrease her ovarian reserve furthermore.
But when patient has
It is definitely going to decrease her ovarian, but I will definitely like to give a trial of DHA. Somehow I have seen that in younger age group they sometimes respond very well to DHA. So maybe by the time I am doing her this thing workup, a very good transvaginal scan by like that has to be performed with a clinician only. This is what I think, that you might many a times you end up deferring with the radiologist opinion. So definitely we all are doing TVS, but we have so many things in our mind. Like we'll see the AMH, we'll see the approach, where how to go and pick up the eggs, and side by side we also see where the ovaries are. Sometimes you see kissing ovaries. It means that it is already grade 3, grade 4 endometriosis. So on the basis of a very good TVS, we can always come to a diagnosis, whether it is grade 1, 2, 3, or 4. So this all we can do. And depending upon that, we all know that grade 3, grade 4, we don't have any space for IUI or like timed intercourse or anything. Straight away go at least freeze the embryos, so that at least they can have, the couple can have their genetically own couple. So that is now, it should be our aim with AMH 0.9. And as Dr. Jyoti has said, that since she's just 30 years old, I think she is going to, her egg quality should be much better. And if we are going to salvage those eggs, make it into embryo, freeze them, and maybe we can transfer later, that will be a better option as for my point of view.
Yeah, so actually we were also trying to touch upon fertility preservation in these
Yeah.
cases, whether endometriosis is an indication for fertility preservation. And it is a very, very strong recommendation that in cases of extensive endometriosis, the clinicians
Grade
should
3, grade
discuss
4,
the
yeah.
pros and cons of fertility preservation with these women. And though the true benefit in these cases still remains unknown. And the impact on the obstetric and pregnancy outcomes, the patient should not be advised to become pregnant with the sole purpose of treating endometriosis, as it does not always lead to improvement of the symptoms and may change in appearance during pregnancy. Next slide, please. So I think this is a role of secondary prevention for recurrence of disease and painful symptoms. In cases of endometriosis recurrence, what do they say is that when surgery is indicated in women with endometrioma, clinicians should perform cystectomy instead of drainage and electrocoagulation for the secondary prevention of dysmenorrhea, dyspareunia, and the non-menstrual pelvic pain. However, the risk of reduced reserve should be taken into account, and the clinician should prescribe post-operative use of a LNG IUS or a combined pill for 18 to 24 months for the secondary prevention of endometriosis associated dysmenorrhea. So actually it is for not for infertility, but for endometriosis recurrence and pain and all that. And after surgical management of ovarian endometrioma in women not immediately seeking conception, then they can be put on long-term hormone treatment like the COCs for the prevention of recurrences. So, but not in, we are not talking, since we are talking of infertility, there we are not giving any such add-ons post-surgery because that is the time when we are trying to put them on, in fact, ovulation induction, and maybe do a IUI, or maybe put, depending on their EFI or their age, the disease, their past history, we can put them on the ART. We should not forget about cancers, because endometriosis, whenever we are doing this, there is a higher risk of cancer overall in these women. And although endometriosis, so we should inform these women. And definitely whenever we get this tissue, we should always send it for a histopath so that we do not miss out on malignancies in these endometriomas. So a counseling is highly recommended. Progestins are the first line drug. Divagest is as effective as a GnRH agonist with less side effects. And it can be given for quite a long time now, maybe 2 years, 3 years, 4 years also. Studies have shown that it is quite, it has less side effects. COCs, NSAIDs can be considered to reduce EAPP. Excision of implants can be considered over ablation. It should be actually, as Dr. Kade suggested, that they should be excised rather than, in fact, that would be the best over ablation. And if you have laser ablation or plasma, then also then you can do that either. And surgical laparoscopy can reduce the overall pain and increase the chances. So thank you so much, Dr. Lakshmi, Doctor, for this for giving us this endometriosis committee along with Dr. Jatinder and Dr. Gurneesh. So the whole committee has come up and done this webinar on endometriosis. So thank you to you all. Thank you to our panelists, Dr. Ishika, Dr. Jyoti Gupta, who could not join, Dr. Anu, Dr. Divya, Dr. Anupma also had to leave, and Dr. Niharika. So thank you to our panelists for giving your insights and your expertise. And also I would like to thank my previous chairpersons of the previous sessions, the 2 talks, Dr. Rakshita, Dr. Renu Chug, Dr. Gurneesh, Dr. Rimi. It was a very interesting session today. Thank you so much, Jagsonpal, Dr. Deepika, and Dr. Lakshmi. Since Dr. Gurneesh or Dr. Lakshmi, you can sort of conclude since Dr. Jatinder is not there. I would just thank everybody and we just say bye.
Thank you, Dr. Jyoti. First of all, I would like to thank Dr. Jyoti and Dr. Minu and the whole team for organizing such a wonderful session of Inspire and Ignite. And as far as the speakers are concerned, it was a pleasure to listen to Dr. Abha Majumdar and Dr. Sandesh Kade, who cleared a lot of my doubts. And after starting laser surgery, I had a lot of doubts, how much I can use, how much I cannot use. And I used to see the videos. I saw a lot of videos of Dr. Sandesh Kade. But here today is clarified how much you can use only for OV and minor surgery, should not use for extensive section with the laser. Most of the points I understood, but there is some place that I have got doubt about Sandesh Gade. Is more into surgery rather than infertility. So many of his, after seeing his videos, it appears that so much resection has been done that at least for 1 to 2 years now, infertility cannot be thought of. So, but overall, it was a very interesting session. And in question answer session also, there were very interesting questions and learned a lot myself. Alternative medications, which I used to straight away go for IVF in most of the things whenever there used to be low MH. And in the surgery of endometriosis, when I used to see that ovaries are not good, straight away go for AMH. Yes, I also got a lot of other perspectives also. So thanks. Thank you again, Dr. Jyoti, Dr. Minu, and all the chairpersons for such a wonderful sessions. Thank you.
Thank you, everyone. And last but not the least, thank you, Dr. Jyoti, Chairperson Haryana ISAR. She's our guiding force, and it's our brainchild, the Inspire and Ignite web series. And we are all learning so much from this. And I would request all of you to join every month. We have second Tuesday of every month. We have this webinar series on different topics in infertility. So you can all join. The link is there in the Haryana ISAR group, and also Dr. Jyoti will tell you about our the e-newsletter, and you can all contribute the articles in that newsletter. So Dr. Jyoti, would you like to tell us about?
Yeah, we will be now inviting articles on ultrasound. So anything related to ultrasound, infertility, endometrium, whatever related, maybe even endometriomas and ultrasound, whatever we can think, fibroids, ultrasound. So we need articles on ultrasound and infertility. It would be my request to please send so that we can have our newsletter every month. And we would be having webinars definitely every month. We are also starting with the journal club fourth Tuesday of every month, where we would be discussing one particular article every time. The new article coming, taking from Fertility, Sterility, or any other infertility journal. And then we would be discussing that, and we would be having national ISAR people guiding us on that, and even the ISAR brigade from national ISAR. I would like also the young ISAR, Haryana ISARians to please join for this, so that we can make our ISAR Haryana brigade, and there one person would be presenting, and we will be asking questions and interacting there. So that is, we would 30th of this month, I think we would start with our first journal club. Thank you so much, Dr. Deepika Jagsonpal, because you are the backbone. You have provided this platform. Over to Dr. Deepika.
Thank you so much for this opportunity, where we could also benefit so much. Learning about endometriosis is a thing for us also, because we do have this product with us, which is Divagest 2 mg tablets of Endoreg. So I'll take this opportunity and thank every one of you, all the faculty and the attendees present today. I'll just be playing a small video.